Greetings, everyone. We're coming to you live from the Coy Center in Seattle, Washington. I am certain there isn't a person watching this learning opportunity that does not have some questions or concerns regarding exactly how to navigate the delivery of dental care in the midst of this COVID-19 pandemic. I'm also sure that most of us have seen more than enough webinars recently and simply want to get back to work. However, we need to know how to get back to work in an environment that is safe for us, our staff, our patients, and in compliance with our respective regulatory bodies. The center has been overwhelmed with questions from our tribe, asking exactly how to accomplish a safe return to practice. In response to this need, I've created a task force at the Coy Center to help us understand the challenges we face and make recommendations based on the scientific information we have now. The task force was composed of current members of our advisory board and our product advisors. I will introduce each member of the task force on the screen when they present their respective section. This group was asked to sort through all the data, literature, and implementation strategies that may be useful in our return to a safe practice. Much information has been available to all of us, but often has left us more confused and unsure about the best practices to adopt. Our goal was to determine what represented today's best evidence, and then secondly, how to implement this evidence into a best practices guide for dental care delivery. Ironically, we found that even among the 11 of us who saw the same data, the same products and protocols, many times we had a very different interpretation of what exactly would be the best practice, except where certain practices are deemed mandatory by our respective governing bodies, which also varies. These recommendations are based on what we know today and acknowledge that what is known continues to change rapidly. Therefore, without clear science, we found many things were vague and required our best judgment. What we are about to present is a consensus of what most of us would do always, and by no means do we feel this is the only way to accomplish your best practice guidelines. This program is broken into 4 major areas that you see on the screen. But we need to be prepared for the gap between how things look on paper and what we will actually do. Over the years of practice, you'll find many of your engrams will need to change. For example, I kept trying to adjust my loops, but my face shield was in the way. My gloves didn't cover the cuffs of my sleeves very well as been recommended, and you'll see. Just even taking photographs is much more labor intensive. So my point is, many of the things that we're used to doing that seem to be a seamless delivery in our care opportunities are going to need to change. In an effort to close the gaps, you will have access to a companion document so that when you see all these images that look like a page on the screen, you can download them for free. Everything is for free in this webinar, and it is recorded and will be released. Johnny, I'd like you to weigh in to explain to all our viewers how they can get access to all these documents.
Sure. So what we did was, if you see on the bottom of the page there where it says support material, that's the URL that every document that you'll see listed will be available for download. It's all free. There's no profile that you need to set up. Everything's available to download free from the website directly. all the PDFs, so you don't need to worry about writing down which documents are where. Everyone's listed in the order that they appear in the webinar. So if you go to coicenter.com, you can click on support materials, or you can type in directly support-material /COVID/-19, and all these documents will be available for download. And there's about 20 of them. It's quite an impressive array of documents for this presentation.
Thank you. So as you look at the page, the reason for the page also is to expedite how we can present the content. I'm not really about, I don't feel it was necessary to discuss basic infection prevention measures. That's why you have a supplement document. And so what you'll see as we go through this, you'll see a lot of the reference material that we've used to provide all the documents and the content. So by now, everyone knows how the virus spreads from person to person. We know about the 6-foot required spacing that would be helpful to reduce the risk of infection. We know, and this is a wonderful citation by Scott Fromm and Michelle, that talked a lot about the droplet infection potential, and you realize the 6 feet doesn't apply if you cough. So it's meant only as a speaking distance, and this is why now the insistence on masks, and actually what was announced today, they're even looking at making masks mandatory in the city of Seattle within the city limits. The third part of this is we also know that the virus can be transmitted by touching objects or surfaces. So there's a second document that's labeled, how long does the virus live on surfaces? So you could just expedite that. You could laminate some of these forms to help what you'd like to do in your practice and how you'd like to educate your staff. When you looked at basic infection, we all now, by now, realize how important it is to wash your hands properly. So you could see the document that you could then laminate and put in the appropriate places in your office, in the restroom, in each operatory, just to remind everyone of how you're supposed to wash your hands, the 20-second rule, the use of sanitizer, the respiratory etiquette that would be encouraged, all the typical things, managing social distancing, all those pieces are just meant to expedite how you could communicate this information as you get back into practice. Now, if we go back a little bit and we try to understand a little bit about Workspace and the dangers that you have, what you're seeing here is an image from about 100 years ago. This is the 1918 flu pandemic. And by now, many of you are aware of this flu. You know it infected 500 million people, which was at that time about 1/3 of the world. The death toll from that pandemic was somewhere in the range of 17 million to 50 million people and possibly higher. It's interesting, just as a side note, to maintain morale during the time that this pandemic came out in World War I, censors minimized early reports of illness and only reported illness in Spain, which was a neutral country at the time, which then gave the impression to the world that the virus was mostly focused in Spain, hence the name Spanish flu. And this one created a cytokine storm, which is why it also was very bad for young people. Now, what's important to understand about virus transmission for us, especially in the work environment, is we're in an aerosol generating environment. And this is what we do on a daily basis. Everyone watching this understands that piece. There was an article in the New York Times which should make us really pay attention to this piece. If you look at this, in order to understand it, it says workers who face the greatest coronavirus risk. It's not actually true when you read the study. It's about work-related risk, and they just assumed it relates to the coronavirus. And I'll have more to say about that in a minute. The reason that you'll see hygienists up at the top is it's based on data from the Department of Labor. The Department of Labor looked at exposure to disease, exposure to radiation, time spent sitting. It accumulates a lot of data. So when you look at the chart, each bubble represents basically an occupation. The bigger the bubble, more people that do it. The vertical position starts to now look at how often workers are exposed. And then the horizontal position measures how close people are to others during their work days. So this is why, even though the practice of dentistry hasn't been tested during the coronavirus, you realize why when data like this comes out, especially this was the hotspot in Seattle, Washington area, when we had a nursing home linked to 25 deaths back in March of 15, and 70 employees had fallen sick. It was an idea how making close contact with people puts you at risk. But in general, what you realize, the top upper right-hand corner does indicate that hygienists are the #1 risk. Now, as a little analogy, there's a picture from my son's practice. He had a fire about a year and a half ago. And that fire started from something very small. It was a battery charger that malfunctioned, melted, and started to melt other plastic equipment in his laboratory. What you're seeing on the left-hand photograph is what happened as it was primarily contained in the laboratory. Then to the immediate right of that, you see the HVAC system. And so what happens in the next 6 hours before it was discovered, all of the carbon that was being released from the melted plastic got sucked into the HVAC system. And what you see on the two images on the right, how much the carbon permeated the entire office within a short period of time. This is to really create a segue for us on where we're going. You know, prior to this time in practice, I looked at air management concepts as mostly climate control and comfortable temperatures in the office, rather than the analogy that really what this is about is a healthy environment. So I want you to think about the carbon in these photographs and think about the coronavirus and think about the carbon actually being like a disclosing agent, showing you exactly what is happening to all the surfaces in your practice. So there's no doubt that we are performing in an aerosol generating environment. And at this point, the dental environment has not really been tested. And it's going to be tested more than ever. I need to encourage all of us to pay attention to the strictest guidelines. Somebody's life may depend on it. This is not a time to freelance a lot of things that you think are okay. We're trying to get guidance from the best evidence because of the serious nature of what we're contending with. Now, the medium environment are going to be for workers that might be within 6 feet, but not making close direct. For lower risk people, we have within the 6 feet, outside the, if you're beyond the 6 feet, you don't have to worry. So I would say at this point,
to be able to
we have some. The panelists mute their mic. Sorry. So I would say at the very least, no one's lower in any dental practice than a medium environment, which would be our front office. So as you think about it, we're either very high to medium, and we need to perform differently. What you see on the screen is what we're about to discuss in the entire office work environment space. What you see in the beginning is the use of fogging with HOCl, which about a month ago, I didn't even know what it was. And you're about to learn some options that you can have that could be very effective in being able to reduce the risk of the virus in your spaces. And you'll see what I mean in a minute. This is also why we've incorporated sneeze guards, or the ability to reduce the droplet transmission that I've already recommended, the need to cover keyboards in any exposed spaces. Some people have gone as far as putting in custom guards to not hurt the look of the practice. And so to help you and minimize how much you have to remember, when you print out the documents, you'll see a front office checklist. And so I've highlighted for you, for example, what you might need to do if you have to bring in an added caregiver, about spacing the chairs, about things that might be necessary depending on your office space. But in order to really take a deeper dive in what we need to know about hypochlorous acid, you have a document that will explain exactly what it is, but I know no one no better qualified to explain what this is than Jeff Bynum. Jeff, could you take this over, please?
Yeah, for sure, thanks. You know, in developing the protocols and formulating these recommendations, we spent a significant amount of time researching many options to make sure that they were adequately backed by science, that they were as effective as possible against these new threats, and that they were safe for our offices. We made every attempt to ensure that the solution or the fix was not worse than the threat itself. In the research of these disinfectants for the office, we came across chlorine-derived disinfectants, and specifically hypochlorous acid, HOCl. We've been using hypochlorous acid as a disinfectant in the food industry and the dairy processing facilities, hospitals, and the water treatment plants for years. And HOCl is a weak acid, and it's a potent disinfectant. And in fact, they say that it's 80 to 120 times more potent than sodium hypochlorite, which is household bleach. And it can be produced in our offices safely and easily, or you can purchase them in a pre-made solution and use them in several ways to disinfect the office. HOCl is sometimes referred to as electrolyzed water, and it can be even made by our ancillary team members in our offices with relatively inexpensive setups consisting of an electrolyzed water system like the Ecolux that you see there from Ecolux Tech, to electrolyze the water and free up the chlorine ions, which give the solution its disinfectant properties. Some simple supplies are required to monitor the solution. You'll need a pH meter or at least some pH strips to make sure that the solution remains in the most effective and as well as the safest range. If the pH is too high or alkaline, then the solution will have more hypochlorite ions and it'll be less effective as a disinfectant. If it's too low or too acidic, the solution will give off a gas that will have an undesirable chlorine odor and potentially somewhat toxic. You'll also need an ORP meter to measure the real-time oxidation reduction potential, ORP. This will tell you the effectiveness or the disinfection ability of your solution, which should be greater than 650 millivolts. The ULV fogger that you see there is an ultra low volume fogger. Is recommended to fog or mist the space you wish to disinfect with the HOCl solution. A fogger should produce a droplet size of less than 50 microns so that the particles will kind of float around in the air and remain in the air longer. And so that when they drop on the surfaces, that they won't wet the surface and douse your office. Fogging is recommended so that the disinfectant will also reach the areas that are difficult or impossible or at least impractical to clean with your standard spray and wipe disinfectants. So to produce HOCl in the office, you'll just need some supplies. You'll need the electrolyzed water system like the Ecolux, and there are others. And you'll need non-iodized table salt, which is NaCl, and you'll need some vinegar or acetic acid. A protocol or a recipe, if you will, that we found to predictably produce the high level of disinfectant properties with the least amount of undesirable side effects, like a pungent chlorine smell, varies slightly from the directions in the box of the Ecolux machine anyway. So what I did is added 1 liter of distilled water And there is a fill line at 1 liter on that particular canister, and add 2 grams of NaCl or table salt, again, non-iodized, and 3 milliliters of vinegar. The vinegar gives it a little bit more acidity so that the solution will remain stable and will allow for the most amount of hypochlorous acid to be produced. There are 3 settings on the machine that is designed for the volume of water added. And using setting number 3, the electrolysis will begin and it'll turn off automatically after 8 minutes. The electrolysis will separate the sodium from the chlorine, and it'll free up that chlorine ion, which will bind to the OH and form the hypochlorous acid. With that recipe produced in that manner, we've been able to consistently produce a solution that is in the 5 to 6 pH range, which is optimal for the disinfectant. And it also will contain the highest amount of HOCl, or hypochlorous acid ions. And the ORP meter reads with that solution somewhere, depending on the time and the temperature, 750 to 1,000 millivolts. And that's well above the minimum that you would need of 650 millivolts. That particular concoction or recipe will produce well over 200 parts per million of free available chlorine. And by all respects, that's a potent disinfectant, and it's also safe and easy to produce. There are a number of companies that create solutions and they sell them pre-made. The costs are higher sometimes, and so you'll want to check that out. And some of the mixtures are concentrates, so you want to know, is it concentrated? Does it need to be diluted, or does it require some mixing of some kind? And others will require no dilution. The manufacturer claims that they have a high shelf life of these products, some of them even into a year or more. And so you could buy in bulk potentially. I would recommend that you test all of these products with the pH meter and also with the ORP meter, so you know exactly what you have. There are also companies that have created other products and they sell them. One is called Sanitrol from a company called Rembrandts, and they claim that they have a potent disinfectant that remains and continues to kill microbes on the countertops after application after 14 days. And so that may be something worth researching. At the moment, I don't currently have enough data, but it would be something that you might want to look into. The use of, the recommendation is to make, our recommendation is to make your hypochlorous acid solution every day. You can make it in 8 minutes, and your ancillary staff members or team members can make that in the office. Or you can purchase it pre-made if you don't want to have them do that or do it yourself. And place the solution into the fogger and fog the entire office nightly or end of day. During the regular workday, you would use your usual EPA registered disinfectant like a Cavicide or Lysol wipes and wipe down the rooms using your normal disinfection protocols, and then fog the office at end of day. You have the option of fogging at lunch or even between patients if you can consistently produce a solution that is relatively odorless. But if not, or if it's not mixed properly, some may find that odor to be a bit disruptive. Another potential disruption may be the noise level of the fogger. Some of those foggers can be quite loud, and while others maybe not so noisy. Fogging with patients present may not be appropriate for every office. We believe, though, that if you use approximately, it'll take you approximately 1 liter of the solution to fog an average sized office. Of course, that's going to depend on the size of your space. But you could make multiple batches of the solution throughout the day if necessary. It's very simply done with just the salt and the vinegar and the water, and turn it on. In 8 minutes, it turns itself off. You don't have to touch it. You don't have to do anything with it. So it could be being made while you're using the solution for something else of the previous batch. Just be aware that the effectiveness of the solution will diminish over time and may only be effective for up to 48 hours. So it's recommended that you produce a batch daily. The recommended time to ensure an effective disinfection is 10 minutes. The formula is for kill time is concentration of the solution times time, the amount of time that it will be in contact. The higher the concentration, obviously, the less time will be needed for an effective kill. Most of these things that we desire to kill will effectively be killed in a much shorter time frame, say 1 to 3 minutes, but allowing the solution to stay longer on the surfaces will ensure effective disinfection of everything. Made properly, the solution should be a potent disinfectant that's not caustic, that doesn't smell too much, is very inexpensive and easy to produce, and produces a very versatile disinfectant. The fogging process should not be too loud or disruptive and not wet the room too much, and carry the disinfectant to those areas that are more difficult to disinfect.
Okay. Thank you, Jeff. That's exactly what we've adopted here at the center. And you can appreciate, you know, it wraps around doorknobs and it really coats all the surfaces without harming the surfaces in any way. We're going to move on to personal protective equipment. Obviously, the controversy on masks and shields and all the other protective equipment that have been in the media space right now, we need to figure out where we're going, and we need to figure out how draconian we need to make this. And that was the whole point. Now, you can appreciate if you're in a low or medium risk exposure, that would be your business team, non-operatory personnel, you really don't need anything other than level 2 or 3 mask, which is typically what we already have in practice. I think the key, the take-home message here is masks must be worn by every employee 100% of the time. It's at no time can we not use a mask in our practice. And you might be wondering, can my employees just wear cloth masks? We didn't want to look like everybody else on the street. We wanted to level up. We're also going to come across, you can appreciate if you're handling any documents, packages, you need to put gloves on, or you need to fog them, or you need to do something to control the coronavirus risk on surfaces. And the front desk needs to stay behind the splash guard at all times, unless they put on a face shield or more exposure-related risk equipment. And so what is really critical for most of us, and the one that we really wanted to focus on, is operatory personnel. Operatory personnel, because as we stated in the beginning, we're all at a very high risk category because of our proximity, aerosol management, or aerosol creation. And so we need to figure out how we're managing that in practice. So what we did do is we took this also from the CDC. This is the basic strategies for donning and doffing your PPEs. And even though you might know how to put them on, there's a lot of details about the use of the equipment that, if you don't pay attention, will render the equipment not that effective. And so I'm going to bring Dean in to move us into understanding a little bit more about face masks.
Yeah, thank you. So there's basically, 3 different types of masks that are designed for infection control. On the left of the screen, you could see the elastomeric respirator. And this is the only one that's truly designed to be reusable or disinfected. And then in the middle and the right, we have our N95 and our surgical masks. So when we look at these masks, go ahead and advance. These are the typical tests that are done for the N95s and the surgical masks, the standardized testing, and more specifically for dentistry, the fluid resistance test, that's more the waterproofness of the mask. And so in terms of the level 1, level 2, level 3, every level up is about a 25% improvement in the waterproofness. But the 2 tests to focus on more for what we're talking about during the pandemic are the bacterial filtration test and the particulate filtration test. And so the bacterial filtration test, what they do is they take droplets, aerosol droplets of about 3 microns mixed with staph, and they measure how far the staph can get through the mask. For the particulate filtration, that has more to do with the air and a much finer particle size, which we'll talk about in just a second about how they do these tests. Go ahead. So I have the next slide. I have a graphic kind of putting these all together just to show everybody, because on paper, the masks look fairly similar. But the main thing for sure on paper, the N95 does have improved bacterial filtration. But when you notice on the particle filtration there, it's a little bit different. It looks low. But the main thing to note is that that test, when they do that, it's not always standardized. So they might do the test for the particle filtration of what % gets through at 1 micron. Or they might do the test at what gets through at 0.1 micron. And we know that the coronavirus is very small, around 0.1. So absolutely, in terms of the particle filtration, the N95 on paper does perform better. Go ahead. And so here's just a graphic showing you, with our aerosols and the viral particles getting carried through the masks, we're looking for the most protection during those types of procedures. And that's just showing how the bacteria over time penetrates through the mask. So with the N95, on the right, this is what you see here. It's definitely a much different mask than our surgical masks. Below, you can see a picture there of the KN95. Now, just a couple things is the N95 on the right, this is a very snug mask for those of you that haven't tried it on, and it's designed to make a face seal, okay? Now, the KN95 on the bottom of the screen, notice that it has ear loops. So the one thing I want to point out for those of you that are looking at these masks, if you have an N95 rated mask that has ear loops, it's counterfeit, okay? Also, on your N95, you notice on the front of it how it's stamped with the NIOSH logo there. If you have an N95 that doesn't have any writing on it, it's counterfeit. So just noting that the mask is definitely rated. The NIOSH is the National Institute for Occupational Safety and Health, and that's the US's version of that standard. The KN95 is the acceptable equivalent from China today, and that's what we've been able to get our hands on a little bit easier. I just want to go through some science though real quick. Here's just some pretty recent articles that actually look at the effectiveness of the N95 respirators versus surgical masks. And you guys can read the bold, is that when you look at these studies, there's actually very little difference. When they do these studies, it's in an open setting, in an outpatient, for instance, the flu, the influenza that comes through every year, and they look at the healthcare providers and which one's wearing which mask and how much of the flu gets through to the healthcare providers. And all of these studies say the same thing, is that they have a very difficult time separating that the N95 performs better in clinical settings. So what I want to say though is 2 things. Number one, absolutely the N95 in a laboratory is designed to perform better. It has a higher rating. But what we don't see with these studies either is them with the dental field. So in all of these studies with an aerosol environment, even though they didn't see a big difference between the 2 masks, they all concluded in a more aerosol environment, the recommendation would absolutely go up to an N95 or KN95 equivalent for those situations. So a graphic here, what's the bigger difference? What's more pertinent to us is fit. So we talked on paper, there's a modest difference between the N95 and the surgical masks, but truly the bigger difference is the way they fit. So on the left, you can see surgical masks are designed to be a barrier for the droplets, right? But they're not really giving us the protection in the aerosols and in the air. The N95 fits much tighter. It's very snug, and it's giving us that more air and aerosol protection. Also with facial hair, it breaks the seal. And that's to the next point in terms of fit. You know, it's been quite challenging to get some of these PPEs. I know we got our hands on some KN95s, and it's one size. You know, a size large that fits my huge face definitely doesn't fit my assistant or my hygienist. And so I want to make this point very clear, is number one, when you're using these masks, there's a seal test, which basically what's really important to really fold the nose piece around, get the fit as good as you can, and you're really testing the positive or negative back pressure of the mask. Does the mask almost move in and out when you breathe, testing the seal? But that's not a fit test. So in industries that require an N95 or an actual elastomeric respirator, a fit test is mandated to guarantee that the mask is fitting your face properly. Because what's very clear with these masks is that if they don't fit, i.e. even if you can't get the right size, they're no better than a surgical mask type 3. So I have it starred there at the bottom though, that in terms of dental healthcare professionals right now, this is not mandated to do a fit test, but it's very important to understand that to get the effectiveness of the N95, it needs to fit very well. When they also, just one more comment, when they do those tests, they're pretty significant where you saw in that photo before where they put the hood over you and they essentially perfume different scents into the hood to see if you can smell it. That's more of the pass or fail test. And then when you move forward to higher level testing, they connect the tube there to the mask and they could actually register how much the air is escaping and how well it's fitting. One more mask recommendation, if you're having trouble with the sizing and you want one more bump to the seal, is Bellis, the app here, is offering this personalized plastic frame. This is a nice service. This was developed in conjunction with Loma Linda. And so this is a free app that you download with your iPhone. And it just takes a matter of seconds to scan your face. And there's a program that develops the frame for you, and then you just email it to yourself if you have a printer, or you send it to your local laboratory to have the frame printed, and then you could fix that over your surgical mask to improve the seal. Just one comment about reuse and disinfection. And so, you know, when there's a mask shortage, this question has come up a lot about what do we do? Is it safe to reuse? And you know, there's no real way to give a good number on how many times you can reuse a mask, but a couple of things I think are really important. Number one is that, which we'll see coming up, is I think a face shield is absolutely preferred to protect your N95 since we're struggling with the amount and availability and cost and all of those things. So number one is the face shield to protect it. You know, you could also, and there's studies on this too, you could also put a type 3 or type 2 mask over the N95 to protect it as well from dropules and droplets and aerosols. But I think it's also a bit of a waste in terms of the PPEs. It also doesn't give you as much face protection. Now, the other big thing, if you're going to reuse the mask, is you're not supposed to touch the inside, okay? You have to keep that sterile and clean if you can. And then in terms of the reuse, this would be my recommendation. This is from the CDC as well, is it's, for me, I'm using more reuse strategies. So essentially you assign a mask to your staff for each day. And then after that day, they put it in a bag and label it. And it needs to stay in that bag for at least 5 days. And then you could work through your masks and start to extend the life of your N95s. In terms of disinfection, you know, there are several companies out there with UV light as well as ovens and heating the mask, you know, 160 degrees for 30 minutes. Just one thing to keep in mind is that the masks we use in dentistry, they're designed to be disposable. And right now there's interim guidance, or there's basically acceptance for these emergency sterilization procedures or disinfection procedures for now. But I think once we can get through and get our stock up and inventory of the PPEs, we'll move absolutely to disposable again. But right now from the CDC, just rotating and using reuse is acceptable. And there are these other techniques, but the main thing also is some of them do a good job of disinfecting the mask, but also you got to look at how it maybe damages the mask. So you want the integrity of the mask to be maintained. You also don't want its capability as a barrier to be diminished. And so in terms of our face mask recommendations at this point today of what we know about the virus, for any aerosol producing procedure, it's N95 or a KN95. And like I reiterated before too, is when this class of mask is fitting acceptably, it's protecting you from the viral aerosols better than a type 3 surgical mask, okay? But if it's not fitting you well, it's not better than a regular surgical mask head to head. And for the non-aerosol producing procedures, your surgical masks are acceptable, okay? And as in the highly recommended, as a standard now in the practice, we've just moved to surgical mask type 3 for all non-aerosol producing procedures. And I'm sure when we learn more about the pandemic and we find out how much level of safety we have, that will be the mask standard for me if things go back to more normal.
Thank you, Dean. So what you have when you download the content is you have a document that summarized exactly what Dean just spoke about. It's in essence a 5-page document, has all the references associated with it so that you won't have to go back just to review the webinar to get the content. You can also get it from the documents themselves. Now, what Dean already mentioned during his presentation is along with the mask, the added protection would come from a face shield of some kind, which has been new to me, as I mentioned earlier in the program. And I'm going to bring Nancy in. Nancy right now is the chairman of the advisory board. Nancy, could you weigh in on face shields for us?
Sure, I'd be glad to, John. As we know, part of personal protective equipment that's mandatory is eye protection. Eye protection includes goggles or face shield, but many of us in the dental profession wear loupes. In that case, goggles can't be worn over face shields. They're just not an option. The face shield, therefore, would be a better use for us than goggles. And also, like Dean said earlier, it prevents the mask from being soiled. There's certain criteria for selecting a face shield. They come in reusable and disposable options, but the disposable options are not really recommended because of cost and availability, and many of them do not accommodate loupes. When looking at the shield of the loupes, it's important in looking at these reusable loupes that it's not too thick. If it's too thick, it'll actually distort the vision when wearing loupes. Also, it's important, as I said, that it can accommodate not just the loupes, but also the light combination that you might be wearing with your loupes. Many of us wear. It's also important that the parts can be easily disinfected because they're reusable. As far as when to wear the face shield, it's mandatory to wear them in all aerosol producing appointments. It's also recommended to use them in non-aerosol producing appointments until we better understand more about the virus and its properties. Face shield disinfection is a critical part of this. And oftentimes when you get them from the manufacturer, they'll have recommended instructions for cleaning and disinfection. But sometimes that's just not available. So in those cases, the CDC has certain recommended steps for disinfecting the face shield. Those include wearing gloves while you're doing the procedure, wipe first the inside, then the outside with a neutral detergent solution or cleaner wipe. Then again, wipe the outside with an EPA registered disinfectant solution for COVID-19. That tends to leave a residue, so you'll want to clean the outside again with clean water or alcohol. You can let the face shield then fully air dry or use clean absorbent towels to dry it. At that point, you can remove your gloves and perform hand hygiene, which you already heard about, but I'll go into again. As far as face shield recommendations, we've got some products here that you might want to consider. The Op 2 is a nice one because it is adjustable and can accommodate loops and light for most types of manufacturers. Some of the lights are right on the frame, and some of the lights are actually separate from the frame. For ones that are separate from the frame, the ultralight optics is a nice option. But for those of us that may have oroscopic, you can actually customize your face shield by first putting the face shield on top of your head, marking where the light comes up against the face shield, and then making a small 1 inch to 1 1/8 inch opening into the face shield so the light comes through. That's illustrated in the picture on the bottom, and if you can determine who that model is in the picture, give yourself a star. This list that all of you will get lists the face shield recommendations and the links to get those. So that's a nice handy support material that all of you have access to. I'm going to move on to personal protective clothing, which is also personal protective equipment. I often refer to it as PPC, and I may be doing that as I'm explaining it. PPC is explained as gowns, uniforms, clinic and lab coats, scrubs, which I'll discuss soon, followed by gloves, head covering, shoe coverings, and shoes. Almost unrecognizable in that picture. But going on to personal protective clothing, I'm going to start with gowns, uniforms, clinic and lab coats, and scrubs. They have a purpose, which I'll discuss, and a certain criteria. The purpose of these the gowns, uniforms, clinic coats, lab coats, and scrubs is to prevent splashes, spray, and splatter of blood or saliva from passing through to clothing, undergarments, or skin beneath. They need to be fluid resistant, long sleeved, and closed at the neckline to meet the criteria for outer protective clothing. Gowns, uniforms, clinic and lab coats, and scrubs must meet that criteria for skin protection to be considered PPC. Therefore, if it's a V-neck type of look that some of the scrubs have, or the lab or clinic coats that expose the skin underneath, those are not acceptable as outer protective clothing, so you need to keep that in mind. Gowns are a really good type of garment to look into because they always are acceptable as far as meeting the criteria. I'll get into the management afterwards, but the employer needs to provide and launder the PPC. It's the employer's responsibility. I'll elaborate later. Start of every day, and actually before every appointment, you need to put on a clean, acceptable, that meets the criteria, PPC over scrubs, office uniform, or attire. And you saw that donning and doffing CDC guideline earlier, and that's a good handy reference as far as how to put it on properly. If the PPC during the day becomes soiled, it must be removed properly in the room and changed. Soiled is defined as soiled with blood or suspected infectious materials. And I'll move on to a little bit more detail on that. The GLC is what I'm calling gowns, lab coats, and clinic coats. And you can see that there's a reusable and disposable on either side. The reason I have gown there is because usually you don't have disposable options for GLC. The clinic staff, which is the doctor, assistant, and hygienist, do two different types of procedures, aerosol generating and non-aerosol generating. That's pretty much all that we do. In aerosol generating, again, if the PPC becomes soiled, it has to immediately be changed, removed and changed. We do have a suggested disinfection GLC protocol because there may be chances during the day, most likely in a non-aerosol generating appointment, that in the professional judgment of the provider, that the gown or GLC is not soiled. In that case, because there is a gown shortage, we do have a suggested disinfection protocol. What that protocol is leaving the gown or GLC in the treatment room. After removal, having an assigned person, could be an assistant or hygienist, depending on your office, spray disinfect it with one of the disinfectants like Jeff went into in great detail, spray it or fog it, leave it in there for the appropriate amount of time for the post-contact disinfection to work, usually about 10 minutes. And then that gown will be available for other appointments. But that would be the suggested disinfectant GLC protocol, not for soiled gowns. We're not recommending that for soiled gowns. And it's more likely in non-aerosol generating procedures, but there could be a possibility in aerosol, but not likely. For hygiene exam, the reason that's on there is, and we'll discuss that later in workflow, but we think it's a good idea to have a dedicated gown or GLC outside the hygiene room, a clean one that can be put on by the doctor before they go into the room to do the hygiene exam. That will usually be a non-aerosol generating appointment. So that gown could conceivably go through the suggested disinfection protocol after the exam. Like I said, we'll get into that a little bit more under workflow, but that is a nice way to handle that type of procedure. For disposable gown, there's no option for disinfection because it is a disposable gown. So whether it's an aerosol generating procedure or a non-aerosol generating procedure, clean gown goes on when you go into the procedure, and that gown comes off and is disposed of afterwards. A disposable gown, again, cannot be disinfected. Also, it's a good idea to have a dedicated gown outside the hygiene exam if it's disposable, if that tends to be your choice. End of day management for disposable is going to be disposed. It'll be disposed after every appointment. For a reusable type of gown, GLC, the end of day management is also the same as if you're taking off a soil gown during the day. It has to be removed, found in the CDC guidelines, as listed on the right. And then there's a laundry option. Some offices have laundry options on site and some are off site. If it's on site, it's a really good idea to have an employee dedicated bag with a biohazard label on the outside, and then follow the CDC guidelines for laundering on site. Off site, many times people have a professional laundry service, and the professional laundry service will actually give you oftentimes dedicated containers to put the soiled GLC or end of day GLC into. So now we're going to get into gloves. Many of you are quite familiar with gloves, I would think, but before putting the gloves on, it's important to wash your hands for 20 seconds and or use a hand sanitizer, as we mentioned earlier, that's over 60% alcohol containing. Proper placement of the gloves means put the gloves over the cuffs of the gown or the GLC. Change of gloves, of course, we know minimally you change the gloves every appointment, between appointments, but they may become damaged or heavily contaminated during appointment and require change during an appointment. Removal of gloves is following the guidelines of the CDC and donning and doffing. Moving on to head covering, we highly recommend using a head covering during these times. Its use is to keep your hair protected during the clinical day so as not to allow viral aerosols to accumulate and create risk that you could take off-site. Same thing as with GLC, there's reusable and disposable options available, as you can see. And you can see in the kind of a clever idea in the lower right-hand corner is you could actually have buttons affixed to your reusable cap and actually put them on in such a way that it pulls the mask up towards, against your face and up towards an area just anterior to your ears. And also it saves your ears from being pulled all day. If you can determine who that is in that picture, give yourself a star. And if you can further determine the name of the orca whale on that bonnet, give yourself 2 stars at least. As far as changing it during the day, use your professional judgment, and same end of day management, launder it on site or off site, depending on what you have available to you. As far as shoe covering goes, we suggest shoe coverings over your shoes. And if you use them, of course, you're going to change them daily or more often if needed. But more importantly, we recommend dedicated shoes kept on site at work. And then end of day management for those would be same thing, a disinfection that I mentioned earlier for the disinfection strategy. Use a fogger or spray on end of day, and for sure they'll have enough contact time overnight when they're left there. We've got some supportive materials that explain in a little more detail what I just went into. and also have a checklist that you could have for your office and download that you could share with your staff, just as a reminder of what to do in the personal protective clothing area.
Thank you, Nancy. I really appreciate that extensive review. And please look at the documents that she created, because there's lots of details that are included in the documents. Nancy went through them very thoroughly, but it's easy to miss in a presentation like this. Now, this is going to be the main focus of the rest of our program. Now that you have some details about equipment, a little bit about the virus, most of which you already knew before you're watching this learning opportunity, we wanted to try to build a workflow model in this aerosol risk environment that we've been speaking about throughout the program. And so it has to start from notifying your patients, how you get your teams together, starting to put protocols together. And I'm going to start with informing patients. And so I'm going to bring Dennis in to discuss a little bit about, even before you open, how do you tell your patients what your practice is going to look like when they come back during the pandemic? Because it's not going to look the same. Dennis?
Yeah, thank you, John. To create a workflow model in an aerosol risk environment, we must communicate with our patients. Our patients want to know what we have been doing, and they deserve to know what we're doing to protect them. For mailing and emailing, we have listed procedures in this document that you're looking at. You may want to consider for your communication. A simple statement to open could be, we're excited to have the opportunity to welcome you back. Our office has always utilized personal protective equipment that has exceeded all CDC guidelines. However, in light of the COVID-19 pandemic, we have instituted additional guidelines and protocols to ensure your safety. There's always fear and apprehension when navigating uncharted waters. Understanding protocols and new materials using a scientific approach is essential, and communicating this information to our patients is just as important, as well as reassuring and comforting to them.
Thank you, Dennis. You know, we've even heard of practitioners explaining to us they've gotten new patients because previous practitioners really didn't explain to patients what they're doing, and patients thought they were maybe too casual about instituting guidelines and reducing the risk. So actually, you can look at it as a bonus opportunity. What you see on the text, there are a number of different items that you could then utilize and customize your own letter, obviously, on your stationery, so that you could pick out all the things that you've done that you have customized in your practice to manage your patient flow. Now, once your patients have been alerted as to what's happening at the practice, there are going to be those patients that are coming in to see you. And so what we've done now at this point is we started a pre-appointment questionnaire. And the pre-appointment questionnaire are going to be questions that are going to have to be sent to patients to prepare them before they come into your practice. I'm going to turn this over to Chris. Chris, if you could take this piece over.
Thank you, John. We've talked a lot about some great subject here, but now it's time to talk about the actual source of the infection, the patient. The objective here is to make sure that your patient is healthy to minimize the risk of disease transmission. It's also an opportunity for you to take time to inform your patient about what their appointment will look like and describe the steps that you're going to go through to ensure their safety. This process is not just a screening tool, it's really also a tool to help you reassure your patients that they're going to receive their care in a protected and secure environment. Prior to your appointment confirmations, you'll have already sent the document out that Dennis just described. So they'll have a pretty good idea of what the visit's going to look like and what they can expect. When your team is confirming the appointments 48 to 72 hours in advance, you're going to send the document again. And this is just so that they can make sure they have a chance to review it and have the opportunity to ask any questions about what they can expect. At this time, you're going to ask these 6 questions. These are pretty critical questions here. They address the majority of situations that would indicate a risk of exposure to COVID-19 for the patient. If they answer yes to any of these questions, you'll delay the appointment for 14 days and reschedule. You have the opportunity to do this in the pre-appointment screening. You'll advise them at that time also to contact their primary care provider to receive some advice about potential testing. Let's say the patient screens negative for all these questions. You'd go ahead and confirm the appointment. At this time, you may also collect payment to eliminate any transactions in the office. You may also discuss any additional PPE fees. What you're trying to do is do as many of these steps outside of the office if they're going to come in, so that you don't have these occurrences and transactions going on in the office. This slide here will show you that the symptoms that we had on the previous slide of the first question are arranged in order of prevalence for COVID-19, with the most frequent ones being at the top. This table will show you a comparison of symptoms for other common illnesses that are confused with COVID-19. You'll note that fever, dry cough, and shortness of breath, or at least fever and dry cough and shortness of breath are the most common symptoms. With the exception of shortness of breath, these symptoms are very, very similar to the flu. So there's can be a little confusion there. But you'll also note that runny nose and sneezing is rare or non-existent in COVID-19. There's also a possible new symptom you may have heard of now called COVID toe, which is not on here, but it's caused by an inflammation in small blood vessels around the toes, and it looks like the toes are red, swollen, and shiny, much like frostbite. A lot of the pediatricians are reporting this in teens and young adults, and the experts basically think that it's just a healthy immune response to the virus, but they have been exposed to the virus. Next slide, please. So now it's the day of the appointment. The patient has been cleared to come in. They arrive in your parking lot. You've instructed them to contact you while they're still in their car. You can use a virtual waiting room like Oryx or other web-based products. This would enable you to perform a lot of the same functions that you would normally do in your waiting room in your reception area. Now at this time, you're going to be asking the same 6 questions again, because it's been 48 to 72 hours since you've had a chance to talk to them, and they may have developed, or these symptoms may have changed since the confirmation call. If they answer yes to any of them at this time, you're going to delay the appointment for 14 days and reschedule again. If it's all no, then you can ask for a payment at this time if this was not done at the confirmation call. So any opportunity you have to create a transaction before they come in is preferable. There's another scenario where you would have a patient that comes with an essential individual, and this is somebody like a parent of a minor, or interpreter, or caretaker. Because this patient is being accompanied and they both come together, you would ask this particular individual the same 6 questions. If they answer yes to any of them, you'll treat this in the same manner as the patient responding yes, since it's possible the patient has had exposure to this other caretaker or essential individual with no symptoms. So you would, again, delay the appointment for 14 days and reschedule. And of course, the same advice to contact primary care provider. So now you have your patient who you're instructed to come to your appointment with a mask on, coming out of the car. You've now determined that all respond, and you alert them to come to your office. If they show up without one, obviously you can provide them with one. You should have your door closed and locked so that you can control the flow of patients into your office. And a sign on the door would be nice, just noting that entry is permitted after screening. This is just to minimize the patients that are going in and out of your office, and you can kind of control the entry and the number of people in your reception area. So your patient arrives with their mask on, they come through the front door. You have your assistant or your hygienist greet them, since they're already going to be in high-risk attire. They've cleaned their unit in advance, they're all ready for the patient, they're coming out and they have the proper attire on. Then you take their temperature. The CDC recommends that if the temperature is 100 degrees or over, you'll recommend rescheduling this appointment in 2 weeks. Remember that your front desk personnel is not in high-risk attire. They're in medium-risk attire, and they may be wearing masks, gowns, and likely behind a sneeze guard. They should not come into the reception area and interact with the patient. You should let your hygienist or your dental assistant that's going to take the patient back do this function. Slide, please. So there's a variety of thermometers that are available to record your patient's temperature. The easiest one is the one you see in the middle there, the IR thermometer that's placed 2 inches away from the forehead. This is something you may want to practice in advance with each other just to get consistent readings from your technique. The one on the left, the well challenge, kind of a gold standard. It gives accurate axillary temperature in about 15 seconds on an adult and about 10 seconds on a child. And then to the right, you'll see their disposable ones. Slide, please. If the patient is normal and they've had a good temperature, and again, all the questions have been answered, this is when you escort them back. You're going to instruct them in advance to just really not touch anything on their way back. If you have an operatory with a door on it, the door is already open, so they don't touch that. They go through the door into the operatory, and then they go ahead and perform some other functions in there. But you're basically trying to avoid any kind of contact with anything bringing your patient back. Next, please. Now, if there's any kind of transaction that has to occur between the patient and a front desk personnel, the front desk person must be behind a sneeze guard barrier like this with masks, gloves, and a gown, disposable or not, to handle any of the paperwork like insurance updates or health history updates or new patient forms. The documents would be passed underneath the space. The front desk personnel grabs it with gloves on, they scan them, and they shred them. And if you use any kind of writing utensils or anything else at the front desk that gets touched, they have to be sanitized with spray, wiped, or you're disposed. And in summary, the workflow we've gone over it in quite detail, but they come out of the car with a mask on, they walk into the reception area. The only people that really deal with this patient is your back office that are already in very high risk attire. You take their temperature, and then if everything's fine, you escort them back to the operatory. They don't touch anything. A lot of this can be done, a lot of the transactions, if possible, can be done with a cloud-based option, and Oryx is an exceptional one for this situation. But really the goal is to try to get as much of these transactions done either during your confirmation call, during their time in the parking lot. You really, at the end of the appointment, if you can just escort them and they get to leave without any kind of transaction at the desk, that's desirable. Touchless is what we're trying to achieve.
Thank you, Chris. So at this point, you can understand where we are. Dennis helped us understand how we inform our patients of what's happening to the practice. Chris just went over the key questions that you're asking these patients prior to coming in, 48 hours before they come in, and the day of they come in, you ask them again. Remember, we've created a document for you so you can download it. You can put it on your own stationery. You can use it however you want to use it in your practice, on messaging, however you go to a touchless system. What we haven't discussed is, what if somebody says yes to these questions? What do you do now? And so you've heard a lot about testing for COVID, the problems with testing. We have Steve, who has a background in biomedical engineering, actually, and I don't know if nobody better to discuss these options than Steve. Steve?
Thanks, John. This has been a subject that's been talked about much in the media, and there's been a lot of information, a lot of confusion, and this is a very fluid area where we're still learning an awful lot. There's two different types of testing we're going to talk about, and we'll get into that in a couple of minutes. The first reason that you're going to recommend testing for patients is if there are any yes answers on the intake questions. If there's elevated temperature over 100 degrees, and also if there's a low reading on a pulse oximeter. And one of the things that we're going to recommend in bringing our patients back, and it's going to be discussed in a little while, is the use of the pulse oximeter. What we've learned about COVID-19 is patients that still are not well and perhaps getting to the second phase where they have more severe illnesses will have blood oxygen levels that are less than 92%. And this is an early sign that that they potentially could have a more serious outcome to this. There was an article in the New York Times about 2 weeks ago by a ICU physician in New York that spoke to this, and this was a fairly important piece. Also, we're going to test people that recovered from COVID-19 to make sure that they're still not in the contagious area. So there are some references here for the testing, and those documents will be available. Our main goal in testing is really to isolate people into 3 groups. The first group is people that are still contagious. And again, we've gone over that: pre-visit screening, in-office screening questionnaires, temperature, pulse oximetry. And there we're gonna do live virus or PCR testing. The second group of people are gonna be people that have made antibodies to this virus because they've either recovered from the virus or they're in the process of recovering. And I will cover that in more detail in a few minutes. And the third group, who's gonna be a large group of people who are vulnerable, who've either not been tested, who've been tested and had negative screenings, or have had antibody testing and show that they have no antibodies to this. For those people, of course, our best infection control protocols that we spent the last part of the seminar talking about is really, really important. So who are we gonna recommend for active virus or PCR testing? Well, it's mandatory for people with yes answers on the intake questionnaire, mandatory for people that have elevated temperatures, and we're not going to see them in further appointments, mandatory for patients whose pulse oximetry is less than 92%. The interpretation on the virus testing, the PCR testing, is either positive or negative. Either they have active virus, where they're going to be they're in the contagious category, and they're the patients that really are at risk to our staff, to each other, and to their family members potentially as well. The testing options for PCR testing are nasal swabs, throat swabs, and salivary diagnostics. This is an image of what the nasal testing looked like. These are the first tests that we heard of in the media quite a bit. These are the first tests that were done. They had high reliability. There are issues in availability of these tests for a long time in our country. In most states, the tests now are more available than they have been. They give reasonably quick and reliable results. The disadvantage is they're not terribly comfortable to undergo, even though they're fairly quick. They have high specificity and sensitivity, so they're accurate tests. There's also a company that actually can give a swab intraorally down by the soft palate and by the pharynx. Again, similar results. These tests are also available, and they're also out there. There is salivary testing that has come through from 3 groups. The oral DNA company, which I'll speak about in a little bit more detail in a couple of minutes, and those of you that have done salivary diagnostics for periodontal disease know the oral DNA company pretty well. Second group from Rutgers University came up with a reliable salivary test about 3 or 4 weeks ago. Those tests are not readily available from that company yet, though. The third company, Microgen DX, has salivary tests that they'll actually ship to your home. If the patient, once the account is set up with the office, they'll ship it to the patient's home, and the cost for those tests is about $99. The oral DNA company has set up a really good test that's got pretty good logistics. It's a dual test. One is a salivary sample, and the second is a small nasal swab that only goes into the nares about less than ½ an inch. And the directions for doing the test are up on the screen, as you can see this. One of the things that we would like to recommend is patients that have long appointments in the office. We would like to have this test done 2 days prior. Oral DNA company, if you ship out that test on a given day, will get you a result. It will go there overnight. They'll receive it overnight, and your result can be gotten the next day. So within 2 days, you'll be able to have a fairly good snapshot of that patient in that period of time to know that they're negative. So we do highly recommend this for long visits. So now we're going to get into the antibody testing, and there's been a wide variety of thoughts on antibody testing. What the antibody test does show us is that it shows us there's been exposure to COVID-19, and it shows us the stages at which that exposure might have been taken. The question about is there a sustained immunity, are the patients immune afterwards? We still don't know enough about this. The suspicion by most of the virologists and epidemiologists is there is some grade of protection for most patients at the back end of this. We really don't know enough about that yet to be able to say that. We highly recommend staff members, especially in areas where there's a dense population and when there's been a lot of cases of COVID, to have the antibody test done before they return to work. And again, all asymptomatic patients we're offering that test to, and it's able to be accomplished by physicians' offices, by phlebotomists, and in many local areas, there are physicians and labs that are doing these tests. They're way more widely available. There are two different types of antibody testing. One is an actual blood test where venipuncture is done. This is preferred. These tests, most of these tests have higher specificity and sensitivity, and they're more reliable, and the results are more reliable. The finger stick tests that are also available are basically all over the map. The FDA has approved a lot of these to be put on the market before vast testing has been done over a big community. So we're not that comfortable with those tests yet, although we think the technology there will improve as time goes. A little explanation of antibodies. What antibodies are our immune system working properly. It's an immune response to any foreign virus or any foreign substances that we get. With viruses, there are basically three different types of antibodies. With the COVID-19 virus, since it's a respiratory virus, one of the early antibodies is called IgA. That antibody is specifically made in the respiratory system in response to the virus and as a protection. And the studies now are starting to show us that patients that have higher IgAs early on are less likely to have a more severe outcome from the disease and are able to battle the disease earlier and not get into the second phase of illness where they might need hospitalization. The IgM antibody is an antibody that's developed just beyond that, when the patient still might be contagious and still may have some clinical signs of the disease. And that's the second in the line. And the third one is the IgG, which are the antibodies that in theory give a more sustained immune response and that we see later on, and we may see it months, if not years, after the patient has been exposed to a virus. With other human viruses, even other COVID-related viruses, this has been the case. So looking a little bit at the timeline, and this is where it gets confusing, and this is where a lot of the misinformation happens. I particularly like this graph because it basically shows where patients may be most contagious. And you can see the viral testing at the beginning of the graph really shows that that's in a more narrow area. And there's a possibility that patient is still contagious even after they don't test positive on the PCR test for a short area of time. And you can see that even IgM antibodies have been produced in that early period of time before the blue line. And those patients technically might still be contagious. So if we have a patient that tests for IgM antibodies, then we know that we want to have that test repeated in 14 days, or a staff member that has that before they come back to work. And we prefer not to have them in the office during that period of time. You can see on the graph there's a second wave in some patients that have a more severe outcome, and it's another wave of IgMs and IgGs being produced. So what we're looking for when we're looking at these tests is for patients to be IgG positive with no IgMs, and then we have a fairly confident snapshot that they're done with the disease, that they may and likely have some level of immunity, although we don't want to speak to that, and we at least know where they are. The tests that were originally put out there showed IgG only, and you can see that there are still tests that only test for IgG, and you can see that they may be missing a big part of the snapshot of what we're really looking for. So these are the main companies right now that have authorizations from the FDA. They're called EUAs, emergency use authorizations. These are done with blood draws, and these tests are now readily available. Vibrant America is a lab that's been around a long time. Many of the functional physicians in this country use that lab for their other tests, and they've done antibody testing for a while and have built a platform for COVID-19 testing. They're the only test right now that shows IgA, IgM, and IgG. There's really no clinical advantage to us to knowing about the IgA unless we were physicians potentially treating patients that may become more severe. From a dental practice point of view, we would like to know the IgMs and the IgGs for reasons that I stated on the previous slide. The lab fee for the Vibrant America test is about $149, and that payment goes directly to the lab. Most of it is reimbursable by medical insurance, and most of the physicians are actually accepting medical insurance for their particular office fee because there's no deductibles and no co-payments in anything that's COVID-19 related, and that's been a national edict. Cole Diagnostics up in Idaho also have kits that they will send to any practitioners, dentists, or physicians that they have an account with. They sell kits in pieces of 10. The lab cost just to get the test run is $50 per kit. And this is another option that you may have if you have a phlebotomist that you may want to use Cole Diagnostics. Quest Diagnostics now has provider-ordered antibody testing. In New York State, Quest Diagnostics only does the IgG antibody, and they're not testing for IgMs. I was told by some people in other states that they have IgM testing as well. I don't know if that's accurate or not. The fee for the Quest Diagnostics, a lab fee for the Quest Diagnostic test is $119, and that has to be ordered by a provider. In some states, it must be a physician. In other states, it can be a dentist or a physician. LabCorp throughout the US provides an antibody test, which also shows IgM and IgG. So we have a lot of opportunities here to be able to get our patients tested beforehand and our staff members tested beforehand if they're asymptomatic or if they've had the disease. So that's basically where we are. The finger stick antibody testing I mentioned a bit. We don't think at this point that that's got a high level of specificity and sensitivity according to the literature, but these tests are readily available and can be purchased for dental offices as well. So the takeaways in the pre-vaccine period are for us, and what we think is any staff member who screens positive on any staff member or patient who screens positive on intake data must have a PCR test before returning to work or before being seen in the office. That's both for staff and for patients. All asymptomatic staff should have antibody screening to determine their immune status. That's highly recommended. It's not going to be as mandatory in areas where we didn't see as much of the COVID virus around. In areas like New York City, where I practice, I think it's an extremely good idea, and we highly recommend it. All patients should be offered antibody screening on their pre-phone contact, pre-appointment. And again, these can usually be executed within 2 or 3 days. We usually get the results in 48 hours for most of these companies. So that's one thing that we can do, and we can create logistics to have that done before the appointment. And again, any patient or staff member that tests IgM positive should be retested in 14 days and really shouldn't return to work, or if it's a patient, shouldn't have dental treatment during that period of time unless it's a severe emergency. So that's basically where we are with testing at this point. Again, this is a fluid subject. If you've listened to the TV and radio and the press, there's a lot of confusion. And I hope that just understanding the timeline, which is really what the big takeaway is, gives some clarity on this situation.
Thank you, Steve. You can all appreciate how wonderful that would be if we actually knew more about our patients. And so that's where the testing can really become so useful in practice, especially longer procedures, sicker patients. It's a really important option. We're going to come back into the workflow option. And now that we've gone through, the patient has now come through the front part of the office, and we've now entered the operatory itself, which is the most highest risk environment that we have. It's the high risk aerosol generating part of the practice. We're going to have to institute some newer protocols for this specific entity. So we're going to start through this workflow. So as we mentioned, when Chris talked about managing the patient as they came into the office, they had all no answers. They don't have an elevated temperature. They were escorted directly back by a staff member in high-risk attire. They're brought into the operatory, and that's typically where you'd want to enter, and if you can, close the door if possible to isolate the room. At that point, we take one of the handouts. This is how to hand wash. That's placed over the sink in the operatory, and we ask the patient to wash their hands. Notice they also have not removed their mask. So they would go through hand washing the way we've talked about before that you're already aware of, and also use the hand sanitizer. Then we would typically have them sit in the chair. This is where we would use the pulse oximeter, and then that's already been discussed before. And you can appreciate there may be some medical compromises that render this a little bit more requiring more interpretation. But in essence, if these readings are low You may have a patient that's sicker than you think, even though they had all no answers and not a fever. So this is an inexpensive option. It's less than $20. It's something that's so easy to use, just clip it on their fingers. So that's how we use that. Now, what we recommend is actually a pre-rinse. Now, here at the center, we've been working with CTX4, which is basically a sodium hypochlorite. It's a high pH, 10.4. It's a mild bleach, 0.2%. Doug Thompson's going to talk more about it when we get into rinses. And there are alternatives that people are recommending, like iodine, like peroxide. We actually are not. There's a couple of reasons. One reason, with certainty, this is also a rinse that we use as a therapeutic rinse for periodontal management, for caries management. So it's nice to be consistent. I've just learned that this option will come in bigger bottles, 16-ounce bottles with pumps on them. And so basically what we do is we ask the patient to now go back, stand back up, go ahead with the pre-rinse, and then they come back down into the chair. Now, when they come back into the chair, we're going to assume that you're going to perform an aerosol generating procedure. And so there are many misconceptions here about how to contain the aerosol, the dangers of the aerosol in many ways. So remember, especially from my background in aerosol management, most of it was related to field management or operative field management, basically just isolation and controlling the field. But here we're talking about something very different. And so there's also many things that seem like they're effective, but they may not be. I'll just give you an example. This is a fairly recent article regarding a rubber dam that's been around for as long as I can remember, thinking that this creates all the isolation and protection for the patient. It doesn't, because what they did is when they looked at the sites on patients, the rubber dam actually allowed the aerosols to bounce back out of the mouth and actually land on the head, hence the need for the bonnet or the head cap. And if you look, using a rubber dam was actually associated with more bacterial colony forming units than not using a rubber dam. And again, as I mentioned, the importance of now covering your head or using some sort of protective added wear, face shield, etc. So this brings us to a highly debated area on aerosol management. And I'm going to bring in our resident expert here. That's going to be Doug Thompson. And we'll start off with transmission of the aerosol, and some of the containment options will follow. Doug, could you take care of this?
Yeah, thanks, John. This is a great article about our aerosols and transmission of aerosols and what we know about it now. And we should be aware that the low and high speed handpieces, our laser therapy, electrosurgery units, ultrasonic scalers, air polishers, even Profi angles spinning can create splatter and some aerosol. Hand instrumentation is going to be a lot less, but air water syringes, even on examination, can also produce aerosol. But the worst are ultrasonic scalers and high-speed handpieces. So we need to be aware that these aerosols that we generate can hang around in the air for 30 minutes to even 2 hours, and in some studies even show longer than that. The HVE, which hygienists maybe traditionally haven't been used to using, will start to become much more commonplace, and different HVE arrangements are going to be necessary. It's really important to understand that the saliva ejector, what we've used a lot in the past, is not adequate for aerosol management, and that the HVE tip that's usually 8 to 9 millimeters is going to be a better option. And we see studies that show it reduces the bioaerosols by 90%, maybe even 95% in some studies. In the next images, you can see the aerosol from the ultrasonic, and this makes intuitive sense if you've been around the ultrasonic and worked with it much, and even spraying air water on the teeth can make a difference. So this chart just shows the different dental devices and which ones are considered to be highly aerosol producing. And that's what this is about. Also, we don't know about our air abrasion systems and how much bacteria are actually released by those, but that's a consideration as well. And we definitely want to use HVE when we're using air abrasion. Now, this is a picture about there's two sources basically of bioaerosols, and one is from the patient when you spray something on the patient, but don't overlook the water lines. We need to make sure the biofilm growth in the water lines, and especially after units have been sitting for a long period of time, these water lines have to be managed. So we have two sources, the coolant water and the patient biofluids. This is actually a quote out of Dr. Molinari's article, and I think it's so significant for us to remember that there is no single approach or a single device that's going to eliminate the risk. These devices can minimize the risk, but there's not one that's going to eliminate it completely. So what we're trying to do is give you best strategies throughout this entire webinar about where the current research is and what's the best way to mitigate or to eliminate, or not to eliminate, but to minimize the risk to you and to our patients. There are, again, a reminder out of the Molinari article about certain devices and barrier protection devices. And one of the keys about several things that can really be great for you is they're inexpensive. So, you know, we have these inexpensive options. You don't have to spend a lot. And again, as we go back to what Dean talked about in the mask section, that the masks can be subject to leakage if they're not well fitted. Fit tests right now are required in some areas, not in others, but I think Dean addressed that well. We also know that the high volume evacuator, we're seeing lots of different devices now that can come out and be hooked to the HVE adapter, many different variations of that. And just a small reminder that the saliva ejector is not adequate for aerosol management. As we start to look further at the aerosols, in conclusion to this particular article, there's potential to spread infection. We know there's potential to spread infection, and we have a paucity of studies, really no great studies that show that people were infected in the dental setting from the dental aerosols. So again, it's not possible to eliminate the risk, but it's very possible that we can lower the risk. And that's what we're doing by these universal barriers, a pre-procedural rinse, as we discussed, a rubber dam. And remember, the rubber dams for isolation, not for aerosol management, because of what John just talked about. And going back to the pre-procedural rinse, one of the things I would mention is if you use salivary diagnostics in your protocols, which we do a lot, you would not want to do the pre-procedural rinse before you did the examination, determining if there was some sort of salivary diagnostics required, especially for checking for pathogens, because you could alter that. So again, what we've reviewed here is just a little bit about aerosols and how to reduce the risk. Now, we looked for a study that would really give us a nice, somewhat of a conclusion on the aerosol topic. In this particular paper, called a scoping review, looked at 5,823 articles. And out of all those articles, 62 are highly acceptable or applicable to what they were looking at. And they really were looking at what are the sources that generate the bioaerosols. We've really discussed that already. What's the microbial load composition of bioaerosols and how do you measure it? And then what's the hazard posed by these different microorganisms? And so what the result or the conclusion of this paper is on the next slide. What we learned from this is that these aerosols can be influenced by airflow. And we have a couple of experts coming up soon to talk about ambient air management in the practice. We also know that the droplet size, the aerosols are very small droplets. Splatter and droplets are bigger droplets. So these are aerosols like John alluded to in the beginning with the fire, where things go through the air. And some of these can stay airborne for hours. And again, and it can spread. So that's the idea. And I think you get that now. But remember, one key piece about whether you get infected or whether your patient gets infected, it depends on the virulence of the biocontaminant, how strong it is. It depends on the dose. It depends on how pathogenic the microorganism is, and it depends on the host's immune response. So all these things have to align in order for someone to get infected. So again, the things we're telling you are not to eliminate the risk, it's to reduce the risk. And what we also learned here is that in the dental setting, there were typically about 16 bacterial species, 23 different species of fungus. You'll notice by bullet point number 1, there were quite a few more in the hospital settings, but we're talking about dental settings. And there's only very, very few studies that talk about or actually show a contamination. We do know, however, that aerosols could be significant from Legionnaire's disease. That's a disease that can be gotten through air ducts, and I think that's pretty well researched. So all aerosols we want to assume can be hazardous, and we want to take best practices methodologies to reduce the risk to both us and to our patients. In surface disinfection protocols, I'd like you to think about the surfaces and the things in our operatory in 3 kind of main areas. We have critical surfaces that we know have to be heat sterilized, or critical things. These are surgical implements, dental tools, different ultrasonic tips. We know the things that have to be heat sterilized. There's some other semi-critical things in our field that can't be heat sterilized, but get contaminated. They have to be handled another way. And then there's non-critical areas like our carpets and our seat covers and those kinds of things that could be handled a little differently. What I do want to remind every office is, and you can even use pieces of this presentation to help make it from the handouts, but there should be some written protocols and guidelines in your office, and you should have an infection control person that keeps that up to date, because this is very fluid and dynamic. So it's going to be continually changing. Check in with the CDC. What I like about this particular image is it reminds us, the blue arrows remind us of areas that sometimes can get overlooked or forgotten. And it's things like the plastic covering over the bite block on the CBCT machine or the Panorex machine, or maybe the apron cover that for radiation protection. Some of these different surfaces require different types of disinfection. So just be aware that if you're using an iPad or electronics, or you have your cell phone and you lay it down on the counter, just remember these surfaces have to be disinfected, and they have to be disinfected differently. Now, there's different covering systems, and Jeff talked about using HOCl. Many of these things can be lightly misted. We had plenty of questions on HOCl in the Q&A, and I tried to get to a lot of them. But these surfaces all require, they can all be sprayed, or they can all be lightly misted, then they can be wiped, and we'll talk a little bit about the methodology for that in the upcoming slides. So our surface barrier techniques, which are our headrest covers and our sleeves for bite blocks, these are essential. Please remember to change those between patients, because sometimes we'll move out of a room with a patient. Somebody needs to come along behind us and make sure that we move those. Now, I have a keyboard in the office, and I don't like to type on the keyboard on one of those thick acrylic coverings. So a little tip for you at the end of bullet point number 1 is I have a patient who owns a hair salon, and she has very thin hair covers with elastic around the edge. And if you pop those over the keyboard, it's very nice, or very inexpensive, very disposable. They're very nice to use, and you can feel the keys through the translucent plastic hair cap. So remember, surface barriers must be changed. We're going to use wipes for all surfaces like our countertops. That's after we use some kind of spray in our non-critical areas. And remember the wipe, dry wipe, or the wipe, discard wipe methodology that we were all taught. And that's you wipe to clean the area, you dry, and then you wipe again to decontaminate. And that's going to be the most successful way to manage the surfaces and to make sure that they're disinfected for the next patient. Again, we want to make sure that our disinfectants are EPA registered. There's plenty of research out there on HOCl. I know different airlines are using it. It's used in hospitals. It typically hasn't been used in the dental setting a lot that we're familiar with. So do check those out and make sure you're comfortable with whatever you're using. Remember that our floors, walls, and our sinks and our common areas, if we do get into the fogging methodology, they'll be covered. But if not, we need some other methodology for cleaning those. And prepare our solutions daily. Make sure the solutions are fresh and that they don't expire or get you beyond their useful life. That's going to be really important. And remember, for the person who's using the disinfectants, to wear the proper protection per the label of the disinfecting that you're using. And always remember that when we're doing these disinfection procedures, that the heavier utility gloves are much more puncture resistant and safer for us than using our latex gloves like we would use in the office.
Thank you, Doug. I really appreciate that. And again, you realize what he's saying. We have no methodology that's 100% perfectly successful. We also don't know with certainty what the effective nature is. And remember, this coronavirus is acting like a disclosing agent. When I mentioned the risk in an aerosol environment, there's a link to a white paper Andrea Shepperson wrote. That's a shout out to our New Zealand group, which really echoed the fact that we've been relatively safe in our environment. We just want to make sure that we stay that way. So in addition to surface management, we need to start looking at air management. And as I mentioned earlier, air management is not just controlling the temperature of your practice, it's controlling the safety of the air. So I'm going to bring in Peter to begin discussing for us ambient air treatment. Peter?
Thank you, John. Thank you, everyone. First, we're going to go ahead and go through some of the studies on ambient air treatment, and then we'll go through possibly some machineries or equipment you guys could also have to use to mitigate some of the spread of the coronavirus. The study you can see right here is on a Brazilian research research, and it talks about the spread of the aerosol, and it's measuring up to two meters of spray from the place where the operation is going on. So if you look at the right picture here, where the splash zone is, actually now we're looking at the blue zone is where the splash zone is. And so it goes down to the knees of the patient, around to the neck, and go even back to the sink of this operatory right here. Next slide, please. Now, if you look in further where the splash goes, this study here from England talks about a right-handed operator and how the aerosol goes and lands on the person. You can see that the chest and the right arm has a lot more. And noticeably, you can see the inside of the mask, there is also some. So the aerosol goes everywhere. If you're left-handed, it'll be opposite. If you're an assistant, actually, it will be just a mirror image of the operator. And the right study here, the important thing to look at is also the aerosol goes right into the inner corner of your eyes. Very interesting. Therefore, the splash, the shield is something that's very important for us to protect ourselves from this aerosol. Now, this study here from China is a pretty nice one that talks about the air cleaner that's placed inside the operatories and the position of where the air cleaner is going to be placed. A is there's no air cleaner. B is right in the corner of the operatory. And C is at near the feet of the patient. And D, or case 3, is near the head of the patient, which you can see where we circled the area with the red circle. That has the lowest amount of aerosol going on in that operatory. Of course, case 4 is behind the operatory, the clinician, which is not a very good place to do it. Next slide, please. Now, there are two terminologies that's been floating around in online and people talk about it. These are the air scrubbers and air purifiers. We need to look at the difference between the two. The air scrubbers are devices that actually reaches out and retrieves and eliminates the odors or the contaminants, whereas the purifiers are used with the HEPA filter. So when you talk about the difference between these, you need to know the difference between these machines. Now, we do have a document prepared for you, so you could download that document and it'll give you a little bit more details on the different equipment you could purchase. What we're going to go into it now is look at basically a few areas which we want to look at. How do we find a good filter or air purifier that can help us mitigate this aerosol issue? There's basically a few areas we're looking at. Number one is technology. Number two is ventilation. Number three is the noise level. And number four is costs. Of course, we're not going to get into cost because that's your budget. How you're going to go ahead and do it is how you work it out in your financial situation. So we're going to concentrate basically on the first three, technology. Of course, as a purifier, you would have to have a good filtration system. And when you look at this filtration system, there are different terminologies which is very confusing to the public. Very cautiously, when you read something, you'll be very careful to read something like HIPAA-like or HIPAA-type. They are not true HIPAA filters, okay? So very, very important. True HIPAA filters 99.97% of the particulates down to 0.3 microns. And then you get a little bit better HIPAA with the OPA HIPAA will go down to 99.9995 particulates on 1.2 micron, which is the size of the coronavirus. Now, there's also ratings in which we will look at. The next slide will tell us. And these are two ratings in which is also very confusing. HIPAA has a classification by the Department of Energy, and then MERV is another one by the American Society of Heating, Refrigeration, and Air Conditioning Engineering. Both of them work pretty much the same. You just need to know the nomenclature. What we're looking at is anything on the HIPAA classification, anything bigger than 13. So H13, 14, U15, all these would be the true HIPAA. On the MERV, you're looking at 17 and above would be the MERV, would be the true HIPAAs. Now, if you look at what the difference between the HIPAA and the OPA filters, this slide here tells you that the OPA filters really gets down to the small particle size, even to the coronavirus. Next slide, please. Ventilation is always one big thing. And in the literature, and go online, search, dental ventilation is recommended to be at 8 to 12 times an hour. So HCPH is air change per hour, okay? Or if there's one person in the whole room, you're looking at 32 CFM. But when you look at deeper into this, the requirements of ventilation, you notice that the auto industry, the auto repair shop has the highest requirement of 127 to 170 CFM per person. And we already alluded that dentistry is one of the highest risks in aerosol exposure. So why not have the same standard as auto repair? So the recommendation here on the commentary is basically we're looking at the operatory ventilations to have 127 to 170 CFM per person, which means if you're in a hygiene room, you're looking at a machine that does 254 to 340 CFM. If you're in the doctor's room, you're looking at something up to 510 CFM. Now, it's very important that we also realize how the airflow goes in the room here. And we hear these negative pressure things around there, but many times, like my office, I have hard time finding a way to have negative pressure because I'm in a professional building, which I don't have any outside windows. So that creates a big problem. So when you look at your venting system, your air conditioning system, where do the air go? How is it flowing within your room is very critical. So these two photos here indicates that this is where you want the air to flow from the head of the operators and the patient to the feet, and where your air purifiers can be placed, and so you can circulate the air back. So go back into your offices and look into, a lot of times you do have the suspended ceilings down. Look where the air vents are. A lot of times they're actually at the feet. So in other words, you have to swap the end vent and the exhaust to get that flowing in the right position. Noise factor is a big problem because you don't want a filter to be in your room to be so loud that you can't even talk to the patient. So we want to look at something in the order less than 60. 60 is conversation. 50 is almost like a refrigerator in a room and you're in the kitchen, you can hardly hear it. When you get into 60, piano playing, all these things. So you want to get something less than 60 around there, so that way you could actually have a conversation with the patients. So with that said, these are some of the recommendations here. In the operatories, we want to have a filter that does somewhere in the UPA range, which is H14 and MERV 18, down to the 1.12 micron. The ultraviolet lights are a good thing to have because sometimes if there's the particles get through the filters, you also could have the ultraviolet light. I'm not going to get into too much of that. Circulation wise, again, you want something greater than 380 CFM. Noise factor, again, you want something around 50 to 60 on the maximum level. Now, these two equipment down here on the right side are the ones we can find that has these qualifications or criteria. One is the AirPura 614, P614. The other one is the SCA 5000C Jade. Are these two that are meeting some of the criteria we have. That's also documented in the document, so you could actually find that. Now, if you bring yourself into the reception room or the business area, it's not so critical. So we are lowering some standards here a little bit to still have a true HEPA filter. Your circulation doesn't need to be as much, but if you have a large waiting room, you need to look at the number of people in the room there and finding a pretty strong, nice filter there. So these are some of the filters here that's also listed on the document, so you can find those out. And finally, the final piece here in this ladder zone issue is the upper room UVGIs. A lot of people are looking into that. My son used to work in Saipan. They have a clinic there, and they're actually looking into getting some of these UVGIs in each of the operatories. So this will be another way to mitigate some of the aerosol that might rise up into the ceiling. So this is something that is useful, but it's nice to have. And I'm going to go ahead and pass it back to John. Thank you.
Thank you, Peter. I was always amazed because that was more about ambient air treatment than I've ever been exposed to in my entire life. I think in addition to one of the parameters that Peter mentioned, noise, ventilation, airflow, because we're able with the Jade unit to turn the air over in an operatory well over 25 times in an hour. And I think the one thing to also consider is our operatories are small, and some of those units have a very big footprint. Some of them have a size that's about almost 2 feet in diameter, so you need to be careful what you choose. Now, from this piece, we need to get into intraoral aerosol management. And our resident expert in this regard is Dave. Dave, could you please take this over for us?
Sure, thank you, John. So we've already established we're high risk because of all these aerosol generating procedures. And so historically, we've used the HVE to get rid of all the aerosols. And it's not very glamorous, but to talk about the HVE, I think it's the best place to attack these aerosols that are causing all the problems. And that, I can't emphasize that enough. So we're recommending, number one, that you get 2 suction tips for all these aerosol generating procedures. So on the left-hand side, you see that you have that the operator, using the one with a shortened tip, and then the assistant using the other one. And what you can do is you can have, if you don't have an assistant, you can just hand it over to the patient and maybe have the patient hold it for you, would be another option. And I know there's offices out there that don't have 2 HVEs hooked up. And so one of the possibilities would be to get a Y connector, or it's not that big of an expense to just change out an amalgam trap and add another HVE holder. John's developed this. So the other option with 2 HVEs is on the right-hand side. John's going to have these manufactured and be able to hook them up to an HVE so you don't have to hold it. So these are all things that are in works, and we're anxious to see what's going to happen with those. On the next slide, let me just go back here. So just before, I'm sorry, I thought there was something else there. So, as an alternative too, there's other devices like the Isolite. If we go back just a little bit, we have the Isolite and the Dry Shield, and really we have all these things also that can be hooked up with either the HVE. And again, some of this is going to have to be done in place because this is so new. We don't know what's going to happen. I mean, one of the potentials could be that we do 3 HVEs. I know we don't know exactly how it's going to do, but we're recommending a minimum of 2. So the key point to this is the tip has to be as close as possible to the source. So if you have a 9mm HVE tip and you're 9 millimeters away, which is 100%, really you lose, like, you only have 10% of the velocity at 9 millimeters away. So the takeaway is, if you get away from the tooth you're working on, you're going to lose velocity. And velocity, I think, is what's going to capture things. So to that point, you want to make sure your suction unit is working adequately. So the manufacturers, they recommend that every 10 years you replace your vacuum unit, but sometimes you don't need to do that. But you should, a simple test could be something as easy as just opening up the vacuum unit in your operatory and then starting to add more and more, open more and more lines, and see if you can hear a drop in the frequency or the pitch when you're opening additional lines. So that would be a really inexpensive way to kind of test your system.
Yeah, believe me, David is an expert in this area. We had to reel him in quite a bit in order to even curtail him to this short presentation he's done right here before he gets into Extraoral in a minute. But he's also shared with me, most of us have only a 2 horsepower motor for our vacuum systems. And that's why as you add more HVEs, the effectiveness goes down quite quickly. And that's why we also need to look into some of the extraoral management systems. And Dave, while you're covering this, why don't you just continue along this one piece too?
Okay. So the last point I want to make about the last piece, though, was just that the beautiful thing about your suction is that you're exhausting all the air out into the sewer or up onto the rooftop. You don't have to do anything with the air that's laden with bacteria and all the junk that's coming out of the mouth. It's getting done. So if I get into this, this second slide, these units, they're recommended. They're not, not essential, but they're recommended. And I think that this could be the future. It could occupy a spot on the floor in our operatory. It used to be occupied by the cuspidor, but right now there's no unit that satisfies all the requirements that are on the left-hand side. But I think that they have a lot of potential. They're great, I think, for pulling a bunch of aerosols away from the work zone. These HVEs, they pull up to almost 100 times more CFM than your HVE tip. So the key points are, you want a velocity about 60 to 80 miles per hour on here. You want a quiet decibel level, and you want a system in here that will filter out the particles, because you have to recirculate this air. Because if you exhaust this air, your ventilation system won't be able to heat and cool your office if that happens. So there's two things at odds with these. Number one, you need fast airflow, and the problem is fast airflow over HEPA filters, it doesn't allow you to filter viruses out very well. So in conclusion, I'd say use 2 HVEs for any aerosol generation procedure, and make sure your vacuum system works well. Thank you.
Thanks, David. So again, when we get into patient management, we wanted to separate the hygiene workflow, because many times they're obviously not working with an assistant. They have different demands. I already mentioned in the beginning, they're actually the highest risk category. And our resident expert here is Doug, to come back on the podium. And you already talked about the fact that, you know, maybe you're not pre-rinsing first because maybe you need to do salivary diagnostics. So there's some nuances here that also have to be brought to light. Doug?
So as we already talked about with the assistants bringing people back to the room and doing the pulse ox, that's really where bullet point 3 picks up here. And I think you understand the workflow really well until this point. And again, this is another reminder, bullet point 4, about the salivary diagnostics, and we covered that, and that's why. And remember, that would be checking for pathogens. I mean, if you want to do a genetic rinse sample, that's not going to be affected by the pre-rinse, but so you have to think about what diagnostic test you might be doing. Again, our pre-rinse of preference is 0.2% sodium hypochlorite. That's our CTX4 rinse, readily available. Nice to know. Thanks, John. I didn't know it was coming back in bigger bottles. That's great. Again, I think for our hygiene team, it's going to be best right now to either have very controlled aerosol management. If you have some kind of external system, then you might want to use air polishing and ultrasonics. But for most of us, till we get this figured out, we probably should put the ultrasonics down, or do very little of it and just go back to doing some hand scaling and some chemotherapeutic irrigation for bacteria management. Our doctor exam protocol is also something that might change a little bit. We need to think about risk stratifying our patients and how often do we really need to see them to do exams. Do we need to do an exam every time they're in the office? If they're coming in 4 times a year, maybe not. And then the hygienist, and as we get to hygiene time wheel, we'll think about making sure our periodontal therapists and our hygiene teams are prepared to have the doctor come to the room when the doctor's ready. It's going to be a big thing for us to figure out when to come out of the operatory. Getting questions about, do I take PPE off when I come out of the operatory? And we're going to have to use our judgment. If it's soiled, or as Nancy covered very nicely, then you're going to have a responsibility to change that. That's why a dedicated hygiene gown might be a good idea. And again, when the patient is discharged, wash their hands. If they feel comfortable having gloves, I know some offices are talking about doing that. Just use your judgment and make sure the patient's comfortable and that they're comfortable egressing from the office. And it depends on what they have to handle on the way out. One thing that we do want to mention is if they have to use the bathroom, either during the procedure or after the procedure, one of the most contaminated areas in the office could become the patient bathroom. This virus is transmitted in feces. There are aerosols from the bathroom. So it'd be a good idea to make sure the bathrooms are thoroughly disinfected after each patient use. And then again, the patient exit from the front desk would be the same. And hopefully we can get into, remember, the ORX system is a contactless system, and there's other contactless systems out there as well. So this is what I hear a lot. Patients are calling me daily. I really want to get my teeth cleaned. And why that is we have stressed the importance to our patient population about the significance of periodontal pathogens and a dysbiotic biofilm and what it could mean to systemic health. And so we have to decide in our practice, if we have healthy patients that have very healthy biofilm, maybe those would be the patients you could delay in bringing back. They don't have to come back so soon. But the patients who really do need to be seen are our diseased patients, our patients that are in some stage of active periodontal therapy, and our patients who are highly susceptible. So if we look at these particular criteria, it might help us stratify how we're going to see patients as we start to re-enter. The study on the right reminds us that periodontal disease is now being cross-referenced to 57 different systemic diseases. We have a whole 2-day course at the center on this periodontal piece. So it's very, very important. And why is that? Because people that are lacking hygiene care, that are susceptible, could have elevated inflammation. Elevated inflammation is a critical key, and management of that is critical. So think about which patients need to come back and who needs to be seen. Now, in the hygiene time wheel, you'll see some clocks on the right-hand side, and this is just a reference to about how many minutes certain things should take, and it's a nice idea to maybe make some adjustments if you need to. We're gonna have to add some time, be flexible, start back a little bit slower, but you know the confirmation of the intake questionnaire is gonna be important. As Chris reminded us, the intake questionnaire was done on the phone or sent by email some days prior. So it's going to be important to do that. The temperature could have been taken outside, could be taken inside. The pulse ox could be done there. But again, we want to have our patients get the hands washed, make sure they're sanitized before they sit down. The pre-rinse, we've already gone over that piece, what our preferred pre-rinse is, but there were many questions about alternatives. Yes, some places are recommending, or some agencies and even dental associations are talking about hydrogen peroxide rinse. I think that the bacterial cidal components of the CTX4 are much more powerful. However, it's an option. On the Q&A, IO rinse was mentioned. That's molecular iodine. I think that's a viable option. So there are other options out there that you could use. And if you see under bullet point number 2, you see the single and double asterisks. I've been asked a lot for the references about bleach and about other efficacy of rinses, and those are at the bottom of this slide, so you can see those references that we used for that. So once we get this piece figured out and what the hygienist is going to do, then we're going to move into our radiographic update, our extraoral exam, our periodontal charting. And during the periodontal charting, it's now nice to avoid paper systems. If we can totally get away with it from that, that would be great. So our voice-activated systems, our assistant-mediated systems would be better. And remember, in extraoral radiography, that might provide a less coughing option than trying to do intraoral. So if you have a Panorex, if that would do, think about what x-rays do my patients really, what radiographic exam does my patient need? And could I maybe do a Panorex now to avoid the coughing and the problems we have with 20 films doing FMX. As we go further into the appointment, now we have to come to deposit removal. This is where we have our bacterial disruption. And again, I just want to reiterate what we've already talked about and outline very good reasoning why we want to limit our aerosols. And if you are going to create an aerosol procedure, an N95 mask that fits well is what we are recommending, and that's what you should do. Remember, we need eye protection. And again, for all the things that were prior mentioned, we have several different devices to do that. And pictured on the screen are some pictures out of some earlier references that I referenced. And then there's other intraoral management devices that can help you. Again, I already mentioned the periodic oral exam. Come when the doctor is available, or be prepared to have the doctor come when they're available. only because we're going to have to be smarter about thinking about when to come in and out of the operatory. It's going to take a little bit more for us to do that. And then again, as we're dismissing the patient and preparing the room for the next patient, we have to make sure that we're always hand washing, offer the patient gloves. They may or may not want those. Be sure to disinfect the patient bathroom, just a reminder. And patients should make sure, we really want to make sure the bathroom is well disinfected after any patient use, including our staff bathroom, by the way. Now, one of the things we also are big proponents of at the Coy Center is overall health and wellness. And this is the whole idea behind our wellness course. I just wanted to put in one slide to remind our therapy team, remind our assisting staff, remind all the people on the team that one of the best things we can do is coach and guide our patients to have a healthy immune system. And the best way they're going to have a healthy immune system is to eat to it. It's going to be to eat to it and live a lifestyle that's conducive to it. Now, in the eating area, one of the big things that is in the literature all over the place is optimized vitamin D. Now, vitamin D in some of our guidelines might show over 30 is okay. It would really be nice to be in that 50 to 70 range of vitamin D, but you want to have optimized vitamin D, critically important. Vitamin C, beta carotenes, some zinc. I don't want to make hardcore nutritional recommendations because these are highly personalized, and what's right for one might not be right for everyone. However, vitamin C, vitamin D, zinc, magnesium, these are typically things well tolerated by people, and they have good literature that they support the immune system. And we want stronger patients for better immunity. That's the idea. And plant compounds are really going to be the best. Plants also have some antimicrobial activity. There was a very nice study recently done. I don't have it here, but there was a very nice study recently done about an optimized diet and periodontal pathogens. So we know we can help our patients in this area as well. And then obviously legumes, low carbohydrate, rich in plant compounds, nuts and seeds. This is where you're going to keep your immune system in tip-top shape. And that's going to be really important. And it's important for you. We're undergoing a lot of stress right now, so it's super important for you to do this as well. I would add mindfulness to this, exercise, all the lifestyle things, which is on our next slide. We have sleep, critically important. Our airway experts at the center have many studies looking at how sleep can alter the immune system. And I think it's well understood and well studied. Exercise, there's no benefit you can get from any kind of pill that you can take than going out and going on a half an hour brisk walk, just even for 35 minutes. Hydration, mindfulness, stay connected. You know, we use the term social distancing. I think we should use social spacing, but we need to be socially connected. So it's very important to stay connected. Nothing's been harder for me than connecting with the people I love and care about during this time, even my own immediate family sometimes. Remember the people who are at most risk. The people who are at most risk often have things about them that you can see when they walk into the office. Obesity, diabetes, hypertension. Many of us are doing blood sugar tests. We're doing hypertension, putting blood pressure cuffs on in practice. Please, if you see any of these people that have these issues, they're highly vulnerable to this virus. And I would just beg you to help them get better care. So modifiable lifestyle factors are huge in this disease as well. So the role of the hygienist in a summary: reinforce the office screening protocols. Make sure we don't take those lightly. Those screening protocols are critical. Why? Because those screening questions are well thought out. And those screening questions are going to prevent most people that are high risk from sitting in your chair. And that's what you want. That's really, really important. Our appropriate masks and PPE have already been really well discussed. Use HVE during your hygiene appointments. Find some of these systems that work. Ask your friends, go on your hygiene chat groups and find out which pieces are working the best. We've outlined some of the things that we think are working really well here for you. Our pre-procedural rinse we've covered several times. We know it's important to reduce aerosols. I do think one thing that I'd like to remind you is in your planning of your patient experience, any printed documentation, if you're going to give something like that, anything you're going to put into a bag, try to prepare and plan for that as much as possible, so we're not going in drawers and finding stuff in the operatory during the appointment. That would be great. If your PPE is ever soiled, even if it's a permanent laundered gown, please change it. You have to change it. That's your obligation. And we need to make sure that we're, you know, if you wouldn't sit down and be treated from the gown you're wearing, change it out for the next person so that it's not contaminated. If your patient needs to use the bathroom, get some help. Someone, when you go back to work with them, someone needs to go in and make sure that bathroom is sanitized. If you're using display models, graphic things to help educate your patients, be aware if you're touching those things that they need to be decontaminated. And again, this is your take-home materials. I think it's very important, since patients trust you, and I'm speaking now to the periodontal therapist and the assisting staff, these patients trust you. And the minute we leave the room, they look up at you and they say, what do you think I should do? Please become educated about the thousands of dollars and the different things we're doing to make everyone safe, and support our efforts. And some of these things can be inexpensive, but some of them are going to take a different kind of investment. And then encourage and educate your patients about lifestyle so we can keep them healthy, and be positive. This is an opportunity. I know right now it's a tremendous burden, but this is an opportunity to redefine what we are and what we mean to the population. Dentistry, as John said, and where we are going to be looked upon differently. And the quality of how you care for your patients is going to generate patient referrals and make you trusted in the community. And that's why we'd love you to be part of our community, because this is the kind of stuff we like to share. So reassure them that they're safe and that you're safe. Don't guarantee them, just reassure them of all the things you're doing.
Thank you, Doug. Now, we haven't really mentioned our laboratory technicians. And, you know, if you look at the highest risk professions that are out there, actually laboratory technicians are number 7 on that list. A lot of it has to do with exposure to contaminants, in addition to what they may be exposed to at the chair. So usually at this time, most laboratory technicians may be interacting with patients, whether it's some type of shade communication or some other type of ancillary part of the protocol. In general, our recommendation is to have laboratory technicians that are seeing patients off-site, maybe in the laboratory, rely on the dentist to do all the pre-screening that we discussed in the beginning. So that would be taken care of for them. Then when the patient comes to the laboratory, they would have to follow the same protocols that we've been discussing in the dental office. That means the patient washes their hands, they follow the chart. They might have a pre-rinse with CTX4 or some other rinse if you decide to use a different one. If they're sitting in the chair and it's typically a non-aerosol generating procedure, we realize that that should be a level 3 mask, but since they're breaching the 6-foot space, they should also wear eye protection that would be a shield. Here's where maybe a disposable shield might be appropriate. Once you use an air water syringe, assume that that's an aerosol producing protocol, and that means it moves you to the higher risk part of the pyramid. So be really careful, and I would also suggest ambient air management for the laboratory as well. So as we've coming to the close of our presentation, remember at this point, we're ready to discharge our patient. As Doug already mentioned, in the hygiene room, it's the same in any operatory. We're asking our patients to wash their hands again before they leave. That's to minimize anything else they touch on the way out. And remember, their hands, their body have been maybe potentially been impregnated with aerosols on them, which are potential contaminants as they walk out the door. And we also recommend that they hand sanitize. Same thing now on the way out. If they have any exit protocols, remember we'd like to go to a touchless system, a cloud-based system would be preferred, some other option of that nature. And remember, if they're doing anything at the counter, it's just like going to the grocery store. You're going to need to handle that with gloves. You're going to need to disinfect the technology that you have available. So in conclusion, in this section, we walked you through the day of appointment. And there's a lot of little steps that are different than what we've created before or what we've been used to before, but it's a new world. We're going back to a new normal. I think what we presented, a lot of it is going to stay there. I don't expect to ever go back to practice exactly the way I practiced in the past. I'm going to be much more cognizant of where I'm going moving forward. So whether that has to do, I have a much more appreciation, by the way, for aerosol management. And so again, you would resort to all your handouts that are given, the checklist, pay attention to those. They summarize things. You should laminate some of them, hand them to your employees, put them in the appropriate places. We tried to do as many things to be helpful, to reduce how much work that you have to do to get prepared to coming back to work. And so in closing, I want to make a few closing comments to make. What I tried to do with the use of our task force, and remember, this program was absolutely impossible without all of the individuals, the 11 of us that weighed in during this presentation. And I like to always make this quote: none of us are smarter than all of us. And it was very apparent as we went through the time that we've just had together. And so I really want to thank you for being with us for this program. Remember, it's being recorded. Remember, all the materials can be downloaded. Remember, it's an option that you can show for your staff. And I'd like to close with a quote that one of our tribe members, Bowley, reminded me of, this wise statement that he provided during our wellness course that is really so true. As we come into thanking all of you for being here, here's the quote I'd like to end with. A healthy man has a million wishes. A sick man only has one. And what I hope that we've reinforced is, as we go back, we don't want to stay on the top of that list. We don't want to be singled out for the potential risks for our patients, or those are going to have even more devastating consequences than what it's going to take to protect yourself, to protect your staff, to protect your patients, to be able to go to work and feel secure about what you're able to provide. We've worked too hard to be where we are today, not to be able to continue in the way we've been able to do it before. So on behalf of our entire task force, we thank you so very, very much. And we really look forward to the day that we can all be together again. And I'll look forward to seeing you all shortly. Thank you so much. And Johnny, I'm going to turn it back to you for a minute. I don't know what kind of questions we had. We thought it would go for about 2.5 hours. We're right in the time frame. Are there any questions that were very frequently asked that maybe we should address while the group is all together?
There are a few. And first, before we get to that, I want everyone to appreciate that the question and answers, we've had over 350 questions that have already been answered by the task force. So while we were doing the presentation, the task force was also answering a lot of the questions. So I really appreciate all the work that everybody did. It was nothing short of amazing. And very, very good questions. A lot of the questions that we've had that are kind of out there right now stem from the recommendation to close ops, if people should be putting doors on ops, and where they should be putting the JADE unit. And I'll kind of do a couple, and if it's required to have both kinds of air units in your practice, if you have the intraoral and the extraoral units.
I'm going to turn that question over to Peter. He's our resident air expert. Peter, could you address that question, please?
Yes, thank you, John and Johnny. Personally, I would put the J unit toward the feet and have a dental vac near the patient. That way you're able to pull the aerosol right off the patient's mouth immediately, and the dental vac would go pretty much placed at the feet level where the J units could pull the air from that area and purify it. That's what I would do. Again, make sure that your air conditioning flow is also from the head back forward, not coming to you. So that way it helps a little bit to get the airflow pulling away from the operation area. Hope that answers the question.
Yeah, and remember from David's program, if you're going to get to suction units, you have to pay attention to a lot of those details about what happens to the air, the velocity of the air, the loudness, the footprint. There's a lot of details that many of the task force are pretty much resident experts in that regard. We had the DAX unit that we recommended, or we looked at. It's a pretty new unit on the market that comes the closest to the specs that David was talking about. But there are a lot of good products out there, and many of you already have been emailing the center, explaining what you're doing. And I think we just really need to pay attention to what we're doing. And obviously the unknown is the outcome of what we're doing. But once we go through this, I think we'll have a much better idea. Johnny, another question?
Sure. And I guess before we get too far into this, a couple of points, everyone. Yes, the webinar is going to be recorded. It is being recorded, and we will be making it available next week. That includes the webinar and all the question and answers. So we'll make that available for everybody. It'll be sometime next week, probably middle of the week. It'll be available on our YouTube and directly on our website. And all of these documents are designed for you to use and share. This is our contribution to getting everybody back to work. So we hope everybody is able to use these and really help get your practice back on its feet. Dr. Acker, there was some questions about the oral DNA that you had listed that you wanted to touch on live. Would you like to speak to those?
Yeah, you know, the PCR options, obviously, the ones we're most happy about are the ones that we can actually execute within a short time of when we have our patients coming in, especially for longer visits. So the oral DNA process gives us that opportunity to really control it. The one where we're sending it to the patient's homes do as well. That's really the take home there. It's just an easier implementation. And none of these are perfect yet. The oral DNA statistics, and again, the statistics did come from the company, but there's high specificity and sensitivity. And Doug, I think Doug can speak a little bit to that as well, because I know he was in direct communication with the rep from Oral DNA on that program.
Yeah, I think one of the things about the oral DNA testing is that the presence of if the test is done properly, the presence of a negative test is highly significant. It's very accurate. If you get a positive test, there could be some inaccuracies there, so I would have that test redone. And if someone tests positive, we have to refer them out for different management, and they shouldn't be seen in the office. Again, I want to reiterate, because I saw the questions coming in. If somebody answers the questionnaire and they fail the questionnaire, they shouldn't be seen in the office. There should be a hiatus of time before that person gets rescheduled. There's also some confusion about the ability for these companies to, are they FDA approved? We have to be careful because there's not many, I don't know there are any tests that are rubber stamped by the FDA, but there are FDA approvals pending. And I would say call the chief science officers of the companies and ask them that question, because what you hear on the street is different from what I'm being told from them. And I'd like them to speak for themselves. So all these companies have chief science officers. That's where you should direct those questions.
One other question that I should have addressed that didn't there. Pulse oximetry. There are some medical conditions that could lead to having pulse oximetry readings that are lower, including emphysema, COPD, Raynaud's disease, which is circulatory. So in patient history, again, we've taken for granted that we're good at taking patient's history, but patient's histories are really an important portion to that. So that's part of the knowledge that we should have there.
Great. And we've seen quite a few questions about different types of products recommended. Should we do a hydrogen peroxide rinse or a dilution of bleach rinse over the CTX4? Dad, do you want to weigh in on any of those other people asking questions about different ones?
Well, we're still big on the bleach option, and you do have an option, and that's from Jorgen Slott's research, even from a number of years ago, about using an over-the-counter option. But we still believe in the sodium hypochlorite rinse as the primary rinse for our management for patients, normally from the dental aspects. And it just so happens it's actually quite effective for the coronavirus as well. So it's a lot easier when you don't have to have too many different products and you don't have to change your protocols too much. We do all the same things. And so for us, it's a quite easy implementation strategy. And I think that doesn't say that you can't use a peroxide or can't use an alternative. I think that's acceptable. But for me in my practice, I'm staying with the CTX4. It's what I've always used. It's what I already have available. And so for me, that works really well. Doug, would you add anything else to that?
Yeah, I would just add one piece, and that is in most of the literature looking at rinse disinfectants, Dr. Slott's was one of the few operators that actually looked and studied sodium hypochlorite a lot. And he's in his papers, it talks about viral suppression. So if it's a rinse that suppresses virus, and he was using even more dilute solutions than what the CTX4 is. So we do know that that would be one of the big differences, is it does promote viral suppression. And he studied it, of course, for herpes viruses and other viruses and periodontal disease, but it's still my favorite. It's also pH.
And, Dr. Bynum, I hope you can comment on the question of disinfection protocol for an intraoral radiographic sensor.
Yeah, for sure. You can certainly wipe your sensors with the product. You could spray the HOCl on there. You could wipe it with that. You could also fog it. The same protocol that you would ordinarily use with EPA registered disinfectant would be perfectly fine for that as well. And then you could fog the room with HOCl after that. Either way.
Yeah,
great. And
incredibly versatile, that disinfectant. It's almost too easy.
Right, for sure.
And then this has come up a couple of times. It's probably good for people to weigh in, is if patients come in with their own PPEs, gloves, do they replace their gloves? Or if they have an N95 mask on now, does that affect their reading with the pulse ox?
Steve?
Yeah, that should not affect the reading with the pulse ox. You're in a range, people that are normal or healthy are in a range of 94 to 99%. So no, that should not affect the pulse oximetry at all. With regards to anything that comes in from the outside, you have to be suspicious of it in any level. That's why getting them right back and washing their hands is probably the most important thing that they can do.
And I doubt most people have an N95 that even fits their face properly. So I doubt they're actually breathing through the respirator piece, which is why I'm sure that question was asked.
And this has come up too. Is there any recommendation for practices that still use paper charts?
It's still the fogging. That's what we would do.
And we haven't really.
Sorry,
Yep.
you could also pass the papers with gloved hands to minimize the transfer.
We haven't really touched on this in the webinar, but Dr. Pickel, maybe you could touch on the idea of reimbursement for additional PPE requirements for the practices.
Currently, that discussion is being had on a variety of levels just because of the awareness of the incredible costs that we're all going to have with PPEs. And discussions in flux right now, but most dental benefit companies are looking at a way of either creating a code and a fee for it, whether and likely on a temporary basis through this pandemic. The other option is looking at changing all of your fees in general to accommodate the extra costs. And I think that the benefit companies are mainly looking at possibly a one-time fee. Nobody has really made a commitment to it yet, but the discussions are definitely being had at this point.
Okay. That was the bulk of the questions that we still had left unanswered. So, Dad, did you want to make any final closing comments?
I just wanted to say, really looking forward to getting a chance to see as many of you as possible at our upcoming symposium in July. I'm hoping that will be able to go on as scheduled. You never know. But I know for sure during that symposium, I won't be able to get my usual hug. We still have to maintain our social distancing, I'm sure, even by that time. But I really want to leave this learning opportunity to do one more thank you to this task force. We've worked solid for over a month, hours and hours plowing through ongoing research, ongoing papers. We've learned so much, and we were so excited about having an opportunity to share this with everyone. I hope you found it as effective as we found it effective for even us. And I hope that you feel comfortable sending us questions, because the questions will only help us improve maybe the emphasis that we have to create moving forward. So we've been here quite a bit of length of time here, but again, I just want to thank everyone for staying with us, and I wish you all stay safe, stay healthy, and I'll look forward to our next opportunity when we're all together. Thank you all so very, very much.